Well, good afternoon, everyone. My name is Carla Ferreira, and I want to thank you all for joining today's nursing rounds. Before we begin, I'd like to take a moment to acknowledge the land we are on. I'm joining you today from UBC's Vancouver Point Grey campus, which is situated on the traditional, ancestral, and unceded territory of the Musqueam people. I recognize that many of you are joining from different places, near and far, each with its own rich history and Indigenous stewards. I invite you to take a moment to reflect on the lands you are on and to recognize the traditional caretakers who have long nurtured them.
And in terms of our format today, I just want to say that we have two wonderful speakers. And so we're going to have Marlene Burrows present first, and following that, Dr. Julie Tipping. So please hold your Q&A for the end, and we'll conclude the session with a kind of combined Q&A session. Thanks.
That's good. So during this hour, we will hear from two of my colleagues from the School of Nursing, Marlene Burrows and Dr. Julie Tipping. Marlene has been a lecturer in the nurse practitioner has been a lecturer in the nurse practitioner program since 2012, where she contributes to advancing nursing practice through clinical expertise, mentorship, and education. Her NP clinical experience includes women's health, travel health, and primary care. Since 2019, she has been providing virtual primary care services to individuals and families across the province. As a result of this experience, Marlene was invited to collaborate with Fraser Health to examine NP's experiences providing virtual health care during the COVID-19 pandemic. And today, Marlene will be presenting her work entitled Examining Nurse Practitioner Experiences in Delivering Virtual Care During the COVID-19 Pandemic. Following Marlene's presentation, Julie will be sharing with us her work entitled How Millennial BSN Faculty Experienced Faculty on Faculty Bullying. Julie is an experienced healthcare specialist who comes to UBC with experience as a nurse educator. Her expertise includes curriculum writing, policy analysis, emergency management, team-based care, and primary care. She holds a Master of Education and a PhD in Educational Leadership. And without further ado, Marlene, let's get started.
Thank you for that kind introduction, Carla. Welcome, everybody. Thank you for joining. As Carla mentioned, I have been working in virtual care for a number of years, and that's what led to myself being invited to work with Fraser Health on this very interesting topic of seeing how nurse practitioners managed during the COVID-19 pandemic. Okay, so I would also like to start with the land acknowledgement and acknowledging that the land that I'm joining you from today is the traditional, ancestral, and unceded territory of the Musqueam people. And I know many of you are joining us from other locations. So as Carla mentioned, yeah, please just take a moment to acknowledge that the lands that you're joining us from this afternoon. All right, so as part of this presentation, I'm going to discuss the background, why this research was important, what kind of led to it, what our objectives were, the different methods that we used, our findings, obviously, and then the recommendations coming out of the study. Okay, so virtual care certainly isn't new to healthcare, has been used for a number of years, but really the rapid, widespread, almost overnight uptake of virtual care was, related to the related to the COVID-19 pandemic. At the beginning of the pandemic, there was very limited knowledge about how nurse practitioners were being educated in their programs regarding virtual care, and there, as well as at Fraser Health. And then there was plenty of literature about how nurse practitioners there was plenty of literature about virtual care and patients' experiences, but very little about nurse practitioners' experiences, and also no known Canadian studies. So that was something we were looking at contributing to the literature. And then finally, at that time, there were no formal virtual healthcare policies in Fraser Health or professional standards related to virtual care. All right, so I think we can all agree that virtual care is here to stay. So it's important nurse practitioners be supported in providing this type of care. But due to the lack of literature, really what we were looking at was trying to fill this literature gap and further establish the provision of virtual care in a thoughtful way to help improve experiences of both patients and nurse practitioners. And then finally, we hope that we can use this research to help inform both undergraduate and graduate curricula, clinical policies, professional standards, and practice supports moving forward. All right, so our research question. So this study was concerned with exploring and describing the experiences of nurse practitioners in the rapid adaptation to virtual care within their clinical environment during the COVID-19 pandemic. Nurse practitioners that worked in different settings, including primary, specialty, and acute care, were invited to participate in this research study. Okay, so in terms of our study objectives, again, the big thing was to investigate the experiences of nurse practitioners. We weren't really sure what we were going to find. So, survey, well, I'll talk about the methodology, but we were kind of casting our net wide, then looking to see what sorts of themes we could pull out. We were also looking to see what challenges nurse practitioners experienced in terms of, was it practice related? Was it systems related? Was it operational? Many challenges definitely came up. And then what sorts of knowledge and skills are required to be able to provide this type of care? What supports are we going to need to put in place? And then finally, to inform future research relating to this area. So this study employed a convergent parallel mixed methods approach. We used electronic surveys, semi-structured interviews with individuals, and focus groups to collect data. The data of the surveys and the interviews were integrated in the overall interpretation of the results to kind of give us a comprehensive overview of how virtual care actually impacted nurse practitioners. So all nurse practitioners that were employed by Fraser Health were invited to participate in this study. Out of the participants invited, 41 agreed. And then 6 of those completed one-on-one interviews, 14 engaged in 5 focus groups. And most nurse practitioners that joined us worked in primary care. So you can see 15, followed by outpatient specialty care clinics, and then mental health and substance use. Additionally, most NPs had quite a bit of experience. They were seasoned nurse practitioners with over 10 years of experience, but we did get a good representation of different experience levels, as you can see. So some new graduates within their first year, and then quite a number of I would say early career NPs with 2 to 4 years experience. Okay, so in terms of our results, in terms of qualitative results, so these findings, oh, I feel like sorry, I think I missed it. I did, I skipped over some slides. Okay, quantitative results first. So most participants agreed or strongly agreed that they felt prepared to provide virtual care during the pandemic, which was a very encouraging finding. So I like to keep this in mind when I think about all the challenges that they did identify, because in the end, it actually went okay. And then over half of the nurse practitioners reported they were actually able to establish relationships within the first virtual visit with their patients, which was also very encouraging. And then interestingly, many nurse practitioners said that they felt virtual care actually improved their efficiency in seeing patients. And what they specifically mentioned was that for patients that maybe missed their appointment or something had to be rescheduled, it was actually easier for nurse practitioners to fit them in or squeeze them in later in the day in between patients. And they were actually quicker at seeing them. So this chart shows differences in care before the pandemic and during the pandemic. And there was a statistically significant increase in time spent providing virtual care, not surprisingly, as well as a statistically significant difference in comfort in providing virtual care, which makes sense. The more you do something, generally, the more comfortable you feel. And another encouraging finding was that there actually wasn't a statistically significant difference in nurse practitioners' perception in the ability to provide culturally safe care. So they still felt, even though the care was virtual, they were still able to kind of meet this very important competency. Okay, and then in terms of qualitative results, the findings of the study sort of highlighted four overarching themes that encapsulated the experiences of nurse practitioners transitioning to provide virtual care. And I'll go through each one of these themes in more detail. So the transition to virtual care fundamentally altered how nurse practitioners built relationships and delivered care. Participants described significant challenges at times in fostering trust and rapport, particularly when care was provided via telephone versus video. One nurse practitioner stated, in the office, when talking to someone about mental health, you can see them welling up. You give them space for tears, emotion, emphasize that it's safe and okay. On the telephone, you can't really see that happening. All you hear is tears on the phone, and the person is alone. So that's very distressing to know. There's no time and space to center that person again. The human part of it's very difficult. Additionally, virtual care also posed challenges for some vulnerable populations. Having video access is not universally accessible to all patients. One nurse practitioner said, I work with a vulnerable population. Before COVID, I would draw pictures on paper, write directions, ask them to repeat that back. Virtual care made this very difficult. The second theme that really came up a lot was uncertainty, hesitation, not being clear about the practice that they're providing due to the rapid need to suddenly switch to virtual care services. Many NPs said that they really had to rely on getting good detailed patient histories to kind of compensate for that lack of being able to do a good physical assessment. One NP summarized the challenge by saying, you're constantly wondering, am I doing this right? Is this enough? Feelings of frustration and anxiety came up, and a few NPs also mentioned feelings of moral distress. Other providers were refusing to see patients in person during the pandemic or closing their practices altogether. And so these NPs were left to kind of shoulder this additional burden, and that was leading to increasing provider burnout. The third theme, nurse practitioners were sort of saying, okay, I need to have more support if I'm going to be able to manage or keep my physical examination skills and procedure skills sort of up to par, because I'm not going to be doing these things. So more support is needed. Additionally, not only education and training for nurse practitioners, but also medical office assistants. NPs repeatedly cited the importance of medical office assistants because they were often involved in triaging patients and then deciding which patients could be seen virtually and in person. And a lot of times there was a variation, from one clinic to another, one MOA to another MOA. So education was really important for them. And then finding training on digital tools. I think this is something we can all relate to. We were told over a weekend, essentially, suddenly we all needed to provide our classes via Zoom. So one participant admitted, I didn't know how to use Zoom. Luckily, my clients preferred telephone rather than Zoom. And then the final theme that came up a lot was safety. It was a recurring theme. NPs would cite issues with privacy, confidentiality. Sometimes they would start a video call with a patient and they didn't really know, is that patient actually alone? Am I able to bring up sensitive topics about mental health or sexual health? Some patients did not have Wi-Fi and they were using public areas like Starbucks or even the library because they didn't have a computer. And that made providing virtual care very difficult. And then, of course, something we still all deal with is just workflow. So dropped calls, unstable internet, and then struggling with digital literacy on both ends, both the nurse practitioner and the patient. And that also came up again with MOAs. Some NPs said MOAs were, I don't want to say difficult, but providing a lot of challenges. And, maybe, they didn't understand how to use Zoom as well. So that all that technical stuff was just kind of shuffled over to the NP to deal with. And that really slowed down their ability to see patients. And then finally, like broader system level issues. So we have virtual care in place, but what about the external system? So what about labs? How are we going to order labs and send requisitions to areas? So those broader systems levels had to be integrated, and those were a challenge for NPs. Okay, so based on the findings, several recommendations can be made to support the integration of virtual care into nurse practitioner practice. And not surprisingly, it first starts with education and training. So one of our recommendations was to incorporate virtual care competencies into both undergraduate and nurse practitioner graduate curriculum, focusing specifically on building confidence in virtual physical assessments. There's actually a lot that can be done well, even though it's a physical assessment over virtual care. You can get patients to palpate and you can get them to do a lot of things. So we're working on integrating that into our curriculum. And then, of course, making sure that we're maintaining cultural safety and privacy considerations. The second recommendation relates to policy development. So developing clear clinical policies and professional standards for virtual care to help guide nurse practitioners making informed decisions about their care. The third is technological support. So this would be on a sort of broader systems level, but investing in IT infrastructure and providing technical support to help both patients and nurse practitioners with digital literacy. And I think those things are I think we're seeing those things rolled out. Workflow optimization. So during the study, a lot of nurse practitioners cited they were unsure what to do. If a patient missed appointment, what's the proper kind of protocol and what to do? They wanted to be equitable to everybody. So making sure those kinds of protocols are in place. And then finally, relational care. So it's very important, as nurses that we provide holistic relational care. So ensuring that we have training in how to properly communicate in both verbal and nonverbal manners with patients in a virtual using video consultations. And that's it. So our article has been accepted for publication in the Canadian Journal of Nursing Research. So we're just waiting for it to be actually on press.
Hi, everybody. Good afternoon. So my name is Julie Tipping, and I am pleased to present to you some research that I did on faculty bullying, looking at the millennial BSN nursing faculty's experience with this. This is a study that explores the critical issues within nursing academia and shedding light on the lived experience of the millennial BSN faculty. So I'd just like to take this moment to say that I'm actually at UBC campus in Vancouver here, and so I'm on the unceded ancestral and territorial lands of the Musqueam people. And I would just invite you to reflect upon this. This is from the Association of the Ontario Midwives, that colonial structures build on inequity and force, creating a breeding ground for bullying behaviors that permeate society. The legacy of colonialism is a culture of dominance, a learned behavior of bullying that persists long after a formal end of the empire. So just something to consider and reflect upon. So my study, this presentation explores the phenomenon of faculty-on-faculty bullying from the perspective of the millennial faculty. The study was completed for my dissertation for my PhD in education and is a representation of the research findings that I found about this topic. Through an interpretive generic qualitative approach, this study examines the nature, impact, and content and context of workplace bullying within academic institutions, offering insights into the significant but often overlooked phenomena. The interpretive generic qualitative study provides structure while maintaining flexibility to incorporate elements of other qualitative methods used during the research process. This approach allows for in-depth exploration of the participants' experiences, perceptions, and interpretations of the workplace bullying within the academic environment. It also prioritizes understanding the meaning the individual ascribes to their experience, making it particularly well suited for investigating complex interpersonal dynamics, such as workplace bullying. By focusing on the millennial BSN faculty specifically, this study acknowledges the unique generational perspectives that may influence how bullying is perceived and experienced. And there is a gap in the research out there that focuses that is limited. There's limited research on the millennial, as millennials are just newly entering into the world of academia, but they are becoming quickly one of the largest generations within academia as well, of employees within academia. Another gap that I found is that the currently research is undecided if millennial workers, especially in academia, are at more or at less risk for becoming a target of workplace bullying. Some hypothesize that millennials, due to their upbringing and different approaches to communication and work ethics from the other generations, such as baby boomers and Generation Xers, might make them a greater target for workplace bullying. However, some comment that millennials that have grown up in an education system that has had anti-bullying policies, especially since their elementary school days, that this exposure might make them more resilient and less tolerant to a bullying culture. For this study, it was grounded in several key theories, and the first was social learning theory by Bandura. This posits that individuals learn and make meaning through their interactions of individuals, environment, and behavior. This theory helps explain how bullying behaviors can be learned and normalized within an environment. The second framework was constructivism by Guba and Lincoln. This perspective suggested that individuals construct their own understanding of their world based on their experiences and prior knowledge. Constructivism helps us understand how millennial faculty members interpret and react to bullying behaviors, especially when those behaviors contradict the expectations they had of the academic environment. So the research that I did identified 4 key themes, and the first theme centered on the negative consequences experienced by the targets of bullying. So participants described a lack of support and mentorship, where they were purposefully denied guidance and feedback from experienced colleagues, including those that were assigned to be their mentor and support their integration into faculty. This lack of support led to feelings of doubt and uncertainty as they navigated institutional policies and sought to excel in their teaching role. But the targets of the bullying also reported experiences with isolation and exclusion. These included exclusion from professional and social circles, having to complete tasks without guidance, being denied learning and research opportunities, all the way to feeling unwelcomed in communal spaces. One participant noted that whenever they went into the staff lounge, the conversation would stop and would only start again when they exited the room. This made them feel unwelcomed, and they eventually stopped using the staff lounge altogether. The impact on the mental health was significant, with participants reporting feelings of loneliness, frustration, exhaustion, and burnout. It's important to note that the research indicates the research found here of the millennial workers who were targets of workplace bullying experienced the same issues as others and other generations in terms of their mental health. So this was not a new finding. It just was in alignment with the other generations. However, what was slightly different was that all of the participants of this study sought outside mental health support to help deal with their feelings while they were going through this. And some still receive mental health even years after the bullying has stopped due to the complete destruction the bullying had on their identity and self-worth. The bullying also impacted their personal lives. It invaded their sleep, causing sleepless nights. It invaded their personal time, making that they had to work during their personal time, and then they had to sacrifice family time. These sacrifices led to feelings of regret and disappointment among the targets. The second theme focused on negative behaviors exhibited by the bullies. The targets reported being criticized for minor issues, often based on personal preferences or historical norms and not rooted in policy. This criticism frequently escalated into humiliation, causing targets to be feeling belittled, embarrassed, and perceive themselves as incompetent due to their lack of experience. One participant commented that even though they had met with the teaching team, including their bully, the day before to review the class agenda, when they started the class the next day, the bully arrived and in front of the whole class said the agenda was wrong and why was the millennial faculty wasting the students' time duplicating this learning. Bullying was also manifested on a scale of passive-aggressive behavior to full-on aggressive behavior. The bullying often started as indirect or covert expressions of hostility, subtle actions, but became more overt, such as mockery, belittling, teasing, and spreading rumors as the bullying progressed. One participant commented that they were having a bad day due to the bully sending them repeated emails asking for the same information, even though they had sent it back to them multiple times. Their bully came to find them and said to them, this is a quote, "I am just your mentor. There is no one else here that can do this, and I think you're just overreacting." This comment made the participant feel like they just wanted to run and hide, and that they never wanted to come back. The bullying behavior also did become aggressive. Some felt they were experiencing people standing over them, invading their personal space, to the point of actually pushing them away and physically touching them. One participant stated that during their annual performance review, they saw that there had been an allegation of sexual harassment on their file because their bully had reported to the dean that the millennial faculty had held the door open for a student. And this had happened several months earlier. And so the millennial faculty asked the dean, why were they not informed of this allegation? And the dean reported that they did not feel this allegation was valid and it held no merit, but refused to take it off the performance evaluation. This millennial faculty had to raise this concern all the way to the level of the provost of the university to have this allegation removed from their record. Another thing that the participants all commented was that the bullying behaviors often intensified over time, becoming more hostile and punitive. This escalation created a climate of fear, making targets reluctant to speak out due to fear of further isolation or retaliation. The third theme explored the reasons for why bullying occurred. Participants identified several contributing factors, but a significant factor was the code of silence, which was prevalent in all of their environments and cultures. This is where concerns were not openly discussed, and it allowed the bullying to persist without consequences. Most of the participants felt that the code of silence is what allowed the bullying behavior to continue up to 2 years in some cases. Power dynamics also played an integral role. Senior faculty often received more privileges, regardless of having equal credentials with the newer millennial faculty, and this created an imbalance in power. One participant noted that their bully stated to them in the middle of a staff meeting that the bully had seniority and it was okay to treat people like that because they had earned their status. Another was a gap between organizational policy and their implementation that made reporting difficult, particularly when bullying was passive-aggressive or it lacked tangible evidence. Participants all felt that the institutional policies lacked clarity and transparency and therefore were ineffective to address the bullying. One participant actually stated, what do you do when you go to look up a non-existent policy on bullying or look for feedback on how the university will handle bullying and there isn't any? You just want to bail. Finally, the participants felt targeted due to their age, experience level, success, and/or credentials. The participants felt that these factors led the bully to feel threatened by them. One participant stated that they were acknowledged during a staff meeting as receiving an award of excellence in teaching, and their bully came over to them and in front of everybody asked the millennial faculty why they had been recognized, as she, the bully, was also an excellent educator. The fourth theme was an unexpected theme and a novel finding, and it presented the unexpected positive outcomes resulting from the bullying experience. This has not been reflected in any of the current literature, this feelings and what this millennial faculty expressed. So after some time for each of the millennial participants, they all reported that they had an unexpected personal growth. And they defined this as development of self-strength, resilience, self-advocacy, and self-awareness. They also emphasize maintaining professionalism and integrity in the face of adversity. And this finding challenges the typical association of bullying environments as unprofessional. In the current research, bullying environments have always been described as unprofessional, and all of these members of this study all took a professional stance and really made that a very integral part of their practice. So these participants challenged and changed how they communicated with the bully to incorporate professional communication, and all of them started to have clear boundary setting. The participants also expressed a commitment to creating supportive workplace cultures and mentoring new faculty. The participants became clearer in how they defined supportive environments to include understanding, encouragement, and assistance, rather than the criticism and ridicule they faced. And all of the participants took a role to be a mentor to new faculty. Many of the participants developed a strong desire to effect positive change and change the culture of their workplaces. Some created simulations to work on bullying to equip other faculty to give them tools to navigate such situations. However, all of the participants included different and changed their teaching perspective to add aspects of bullying in their teaching. They felt it was imperative to teach the newer generation of nurses about workplace bullying and give them some skills to navigate workplace bullying if it occurred. So there were several recommendations for future research, as this was just a starting, beginning, novice integral piece to look at how millennial faculty experience faculty-on-faculty bullying. So one of the directions for future research that I suggested was that the expansion of institutional scope to include various types of institutions, such as colleges and technical schools that teach nursing, to examine how institutional types relate to the bullying experience. I also suggested the diversification of data collection methods by incorporating other methods such as focus groups, meeting notes, and participant observations to gather more nuanced and comprehensive data. And lastly, the further investigation is needed to explore the generational factors, specifically whether it's age or experience level that is the primary factor in bullying, and whether other generations experience similar positive outcomes following the bullying. Specifically, research should investigate if other generations report the transformative outcomes similar to those found in this study. So this study provides valuable preliminary insights into the experiences of millennial faculty with bullying in nursing education. These insights can help inform for the development of more comprehensive understanding of this issue and help us work towards creating healthier and more supportive academic environments. Thank you for your time, and I am now happy to answer any questions you have.
With 2 minutes to spare, I just want to say thank you again so much for sharing your expertise with us, and for the attendees for lending us your lunch hour. Thank you so much for joining.